Welcome to the University of Michigan Dentistry Podcast Series, promoting oral health care worldwide.
Our next speaker is Dr. Poticny, and he has maintained a private practice in Dallas-Fort Worth area since 1983. He is the co-founder for the Southwest Center for Advanced Clinical Studies and the Fully Integrated Practice, which is dedicated to education and mentoring for digital process and ceramic dentistry. As one of the earliest adopters of Chairside CAD/CAM, he has maintained a special emphasis on ceramics and metal-free restorative dentistry. He has educated dentists worldwide to the possibilities that digital process and a metal-free approach offer to patients and dentists alike. He is widely published and has presented worldwide on a broad range of topics, including materials, digital processes, clinical application, and applied research. He serves as a consultant to various dental manufacturers and is an editorial reviewer for Elsevier publications. Today, he will discuss current innovations for chairside CAD/CAM dentistry with a focus on the CEREC AC and E4D systems. Dr. Poticny?
Welcome, everybody. And kind of looking in the audience, just why does everybody sit in the back over there? Kind of looks like a Catholic church. Now, in a Baptist church, they're all down in the front. So I know the difference between the two. It's my pleasure to be here today. And my intent, we heard a very nice presentation earlier, and I'm kind of the lightweight in this group over here. So I'm going to be a gap filler, if you will, because for most of my life I've been in private practice. And just recently this assignment I have here at the dental school, which I feel grateful for and hope will be a rewarding experience, has led me down a road that I'd like to share with you, because the majority of you, when you leave this particular institution, are going to find the world to be an extremely different place, particularly as it comes to the practice of dentistry. And no matter what your political beliefs are, you'll find, just like I did when I graduated from school in 1983, that the world was a daunting place. Now consider back to 1983, I have to tell you that as a student, I worked a couple of jobs when I was in dental school, which is really almost impractical for anyone today. And I had the good fortune of meeting my lovely wife. We have hygienists here today, I'm curious? Okay, so my wife was a hygienist, and I had the expectation, of course, when I graduated from school that my wife was going to practice. Let me just tell you something, guys, if you marry a hygienist, don't count on it. She married a dentist, and she lasted about 2 years, and that was the end of the story. But what I will say is my time in dental school was a great experience. And whether or not you find it to be that way, you're going to think a little bit differently about how you practice dentistry. Because success for you today here in the clinic won't necessarily be your barometer for success tomorrow and into the future. All of you will graduate, and all of you will be judged, all of you are currently being judged by grades, but how will you be judged in the future? You'll be judged by your patients, because there will be no one to grade you other than yourself, and your patients will be your barometer for success. Because tomorrow can be a different place. In my own practice, I practice in Grand Prairie, Texas, which is directly between Dallas and Fort Worth. It occurred to me that when I got out of dental school, and I have to tell you that for me, dental school was a little bit of a different experience, because I had my training and education was not in the basic sciences. As a matter of fact, I was a business major. And by the way, I went to that school, that other school, directly east of us over here. So I'm a Buckeye. And I have to tell you that I never really did think I would become a dentist, because it was the farthest thing from my mind. So this was a second career for me. And I have to tell you, it's been a very rewarding career, and it was the best decision I ever made in my life. But that being said, what I learned pretty quickly in coming out of school was, I was a good student, but I realized that once the rubber hit the road and I was out there, I had to start thinking again, and I had to really start thinking in a different way. I wanted to do sound clinical dentistry, and that's really what I'm going to talk about. How do you face the unique challenges that you're going to see in everyday dentistry? Because I'll tell you quite frankly that the everyday world of dentistry is not doing a 16-unit case. 10% of you may do those kinds of cases. For the rest of you, you'll be a family practitioner, much like myself. Those cases won't always be the staple of every one of your practices, because you'll be faced with treating people who come in for one specific condition and may have a pocketbook that only extends to the treatment of that particular condition. You're going to have to manage this with the idea that we've been taught well here in the school, we know how to do dentistry, and we know what constitutes standard of care. How do you address and how do you translate those types of things into the everyday practice? There's a lot of competition out there. And if these statistics are correct, we're currently graduating somewhat over 4,500 clinicians a year. And in looking at the numbers that you see out there, and with economies being what they are today, there are practitioners that are hanging on to practice longer. The population isn't necessarily growing anymore, but the economy has put a definite damper on everything that we do. And still, we have to treat patients. And we have to do them to the best of our ability. You want to be able to sit down, don't we, every day and do things as well as we can. Yet, we're also going to be bothered by the noise of everyday practice because insurance, there are issues. Just as a matter of fact, when I walked into the school today, I mistakenly walked onto the second floor. Then I happened to share the elevator with a group going down, and the guy was telling the other guy, he says, you know, things really aren't too good. He goes, man, my business has been really, really bad. I think he was a machinist or something like that. And all of them were getting their care at the school, and the other lady said, yes, as a matter of fact, she says, I'm really glad that we have the school here to be able to get the kind of care we need for a lower fee. But tomorrow, it'll be different. Because for some of you, for most of you, you won't be doing dentistry for those kinds of fees, and you'll have to be thinking about how you're going to address that. I know a little bit about competition, at least in terms of where I practice, because I'm in a really narrow zip code where I'm at, and in my particular practice, I'm surrounded by 46 or 48 dentists. And I could not believe. In that particular area where I'm at, if you look at a map that I just happened to see here in the paper just the other day, it was 2 weeks ago as a matter of fact, the foreclosure rates were the highest of anywhere between Tarrant and Dallas County, which shares the Dallas-Fort Worth Metroplex. That's what the world's like. That's what the world's like. Yet we still want to be sound clinicians, because you see in a case like this that I did, where this is a direct veneer case that was done with a same-day delivery for the patient, and it was done by use of a CAD/CAM process. You won't be doing cases like this every day. Instead, it'll be in the trenches dentistry that, if you approach it correctly, can be very satisfying. But unlike all of you here today in this room, you'll have the advantage of things that I really never had the advantage of in graduating from school in 1983. Because here's your first case. That comes into your office. Now, this happens all the time. Of course, when they're in the school, this doesn't necessarily happen this way, but this happens to be my mother-in-law's best friend. And as the saying goes, I think Mary has more money than God. And she expects treatment that day. So what's your treatment plan? Now, keep in mind that I'm already running at least 15 or 20 minutes behind, and in my particular practice, I don't do what we call a lot of chair hopping. Most of my patients are seen one at a time, and I may occasionally double book here and there, but I have the belief that when a patient comes to the office, that they have the right and the privilege to expect individualized treatment. And that's the way I've always chosen to practice. So how do you treat this case? What do you do? How do you get the patient to her luncheon such that she can make it and not be embarrassed, and keep in mind that she expects me to drop everything that I'm doing here to take care of something? Well, would the idea of an automated process appeal to you? Because what I'll show you here in this particular segment is a way that we provisionalize the patient. You're looking at the provisional for the patient. Because keep in mind, I think most of you would reason with me, that the treatment for that particular incisor would be what? Endodontics, a post, and then a crown. So how do you meet the objectives of a demanding patient and do it within the constraints of good, sound clinical dentistry? Well, what you're looking at here is a virtual mock-up of the restoration that was done in a virtual way, and the restoration was actually milled, and you'll see the actual design process, for which I'll play a short video clip as you see here. Now keep in mind that in my office, as will probably be in yours, the assistants will make the provisional restorations, which is what my assistant is in essence doing here. The difference is we captured images with a digital device. In this case, it was the CEREC camera, which is not unlike any of the other cameras that are on the market. And the models were actually developed in less than about 2 minutes. And what you're looking at now is the assistant, Melanie, designing this particular restoration, going through what amounts to an intuitive process, much like you would design or create a restoration for a patient here in the dental school. So you make a model, you mark your margins, and then you go on with the design. So as we proceed forward here, any discrepancies in the margin can be marked, and this is just a different way of viewing the same thing that was shown to you just a little bit earlier. And the next phase will take us to the construction of the physical restoration itself. We'll align the model to let the software give us an opportunity to create an optimal proposal. And within a few seconds, the software does its job, and you'll be looking at what the computer thinks could be the best case scenario for your patient. There'll be a few minor edits done to the restoration, and as the restoration is created, the operator, of course, will have the opportunity to create or to address imperfections that the software naturally will introduce, or to make edits as the operator desires. In this case, what you're looking at here is a virtual reduction tool. In other words, it's alerting the operator to the fact that the restoration may not meet the minimal parameter required for the thickness of the material that's used. So a few quick edits are made using a variety of tools. And this is nothing unusual because laboratories have a variety of different types of softwares to use. And there is currently more than one device to do a chairside restoration with. And as you can see here, very quickly, a restoration can be constructed, which is what you saw earlier in the program. Now, so what do? We temporized the patient. That entire process took 30 minutes. That entire provisional was crafted and bonded into place in the incisor position without doing anything else to the tooth because I had to do the endodontics on it. So what do? We brought the patient back for the endodontics. We put a glass fiber post into the tooth. And now your challenge is, really, as they say in golf, for anyone that plays golf, only God can hit a 1-iron. Well, when you get into private practice, try matching a central incisor sometime. That is perhaps the most difficult challenge you'll ever face in dentistry. Commonly, they're done in pairs for obvious reasons. Symmetry and the bilateral nature of two restorations side by side. But not necessarily all the case. The only way to do that, because as you can tell here, it is quite possible for a dentist to be a technician. And that original provisional that you saw there is actually the final restoration. The only thing I lacked was the ability to do the endodontics in the post, which was completed at the second appointment and the final restoration placed. Now, does anyone operate in a workflow like that in this particular room? Probably not. Many people have been doing this for a very long time. It's nothing new. Where do you think your future is? And it also brings up the question about how you're going to view the people that you serve. There's a book written by a man named Carl Sewell. Is anyone from Dallas here at all? I guess not. So, oh, we have some people waving in the back over here. Welcome. Howdy. I do remember that. In truth, Carl Sewell, if you don't know from the back over there, he's a car dealer. And he talked about having a customer for life, because you may want to have the same thing too. You probably, when you get into practice, will not want to have a revolving door. I've had patients in my practice for nearly the 30 years that I've been in practice. And one of the things I have learned over time is you better, if you're going to do this and expect this, have the ability to recognize that you're going to have to treat that patient again. Because 80% of what all dentists do today is retreatment. It's not new treatment. So every time you sit down and you treat a patient, well, I know this now, but I didn't know it earlier, of course, is that you have to plan for the obvious, because they'll be with you sometimes for the rest of your life. And that can be a good thing, or it can be a bad thing. Because how can we, as practitioners, who are focused on the beautiful margins that you saw earlier in the presentation, how is it that we focus on tripodized occlusion and all these things that really mean something to us, and how do we translate that into something that means something to a patient? Do you really believe a patient can appreciate your margins? Will they respect you for that? How do we take good, sound clinical dentistry and make it something that the patient values? Because you'll learn that a patient can never read a radiograph. That's one thing I've learned. Don't ever try to teach a patient to read a radiograph. They can't. They'll do this, but they're going like this, because they always ask the assistant when I leave the room, what did he say? Or how did he do it? These kinds of things really, really matter, because what we want to do the best we can, take no shortcuts, and help the patient have an appreciation for what some people will call dental work. Because in truth, the consumer of today is really much different than the consumer of yesterday. And I know this just from when I graduated from school in 1983. It was not uncommon for me in my practice in 1985, from 1983 to 1985, and even beyond, for people to have the expectation to lose teeth and wind up with dentures as final treatment. The patient that I have today, which is the generation that we see here in the audience, you have different expectations, and so will your patients. And how you address that will be a large determinant in how well you succeed. And this is really where Chairside CAD/CAM comes into play, because I am not a proponent for any one type of system. And my disclaimer would be is that yes, I have received honorariums. I have done work for major manufacturers in the past. But this is independent of what I'm speaking to today. It's about real in-the-trenches dentistry, and there is more than one way to do things. These are alternative means, and this is not the only way to do it. For instance, CEREC, and you see another system that's on the market that's a capable system for producing restorations at the chair. You're going to have to think about these things in terms of whether or not it comes into play in your own practice. Or it may be something you want to put into play immediately when you graduate from dental school. Because the typical scenario in just about every dental office that you'll visit across the United States is a simple one. Doctor, I broke my tooth. Call taken by your receptionist. You come in, you see the patient. Yes, Mrs. Jones, I can see your tooth is broken. We have an x-ray over here, and we will ask that you come back. You'll have treatment for it, and then, once the treatment is complete, we'll have a little provisional, and then, third time around, you can come in, and we'll have you all fixed up. Now, it's a model that's worked for years and worked very well. But it's something that always comes to my mind is, wouldn't it be best if we could do more direct treatment and do it efficiently with the same level of competency that we have grown accustomed to when doing indirect procedures? That makes sense. In other words, would it make sense to leave a wound open for a 2-3 week period of time. Now, I don't know how you do endodontic treatment here today in the clinic, but is the same day endodontics done here in the school? I don't know. I would have to ask that question. Well, I can tell you, and I know dentists will laugh when I say this, but when I was in dental school, if you did a root canal in one visit, you were condemned to hell when you died, because it just didn't happen that way. You see? And this is how our thinking has changed, and this is where direct application comes into play, because my concept has always been, it's not always a valid statement to say today that it needs to take weeks to make a crown, because it doesn't. And this is really what the capabilities of these particular systems speak to. How do you treat this case? There are alternative means. Now, I think most of you looking back there in the audience, ooh, geez, that walks into my office. How am I going to do that? So what do you think? Someone give me a clue. What's the usual treatment back there? D4s, what are they? Endodontics, right? More than likely. Nice post, right? And then perhaps a crown. Is everybody in agreement with me over here? So this is the way we treated our patient. And that was done in one visit, and that's a clinically validated technique. You can go back through the literature and you can look. And it's not a matter of materials, just a way of treating something that may make you think just a little bit differently on how you can handle a particular patient. And how people think is sometimes very important. That's all right. It's a video, or it's audio from a patient, and the story goes, she says, you know, my husband had something like this done one time, and I was just really, really impressed. So how does she do things like most people do today? They Google you and they look for people who can do these kinds of things. You will have people that will ask you to do the same kinds of things, because your mentality for you going forward will be different than the mentality that I had when I practiced. And it's not to say that I know more than you. I don't. The opportunities that you have are far greater than the ones that I had, and I think most of us had when we were graduated from dental school. Because the real question for all of you is how will you create value for the services that you provide? How will you translate your clinical application, the acumen that you've required here, and make it into something that the patient truly respects? Much of what's happened today is happening as a result not because people want to do things digitally, but the materials of the future will dictate a different way for you to practice dentistry. Because in the past, and even today, we still use the material, and they're great, they've proven themselves. The expectation of the patient and the development of these materials happen to coincide. For instance, this is a particular situation that we had the patient in a couple of temporaries for quite a while. And you'll see a lot of patients like this, and I'm sure you see them in practice today. A lot of patients are on medications today. And a lot of patients develop dry mouths, and their caries risk shoots out the ceiling. This guy was so bad that within about 8 or 9 months, he'd gone through a variety of health problems. His saliva output was probably 10 or 15% of what it normally was. And from the time I had seen him about a year earlier, he had developed quite a bit of decay. So in the caries risk assessment process, my typical protocol for something like this would be to take the patient and to see if we can manage. And once we manage, then go ahead and proceed to final treatment. But much like we tend to do things today, I do things in a digital way. We go ahead and virtually create, do our physical preparations, virtually render the models, and virtually design them. And materials today now give us opportunities to use things that are specific to the needs of the patient. Because a metal restoration won't always fill a specific need for a patient, nor will a ceramic restoration, nor will a composite restoration. We have to apply everything that we've gained in our knowledge, in terms of what we've learned here and what we see in clinical application in the world, to develop good clinical outcomes. Because the second molar that you see here is a composite, or what amount, I can't technically call it a composite, but for all practical purposes, let's say it is. The material next to it is an all ceramic restoration. Do they look appreciably different to you? They look virtually identical. These are the kinds of things that are your future, that are here today. And this is the kind of decision making that you'll be doing. Because even with the ceramic materials that we have today, I never for one moment would have ever have thought that I'd see a blue restoration. Because we deal with materials like this on an everyday basis. This is a very common lab material. It's a block material. It's a lithium disilicate. It's a high-strength ceramic, which can also function as a substructure, but it can also function as a restoration. And for a chairside dentist, they have the capability of using the very same material. You may, in fact, have a patient that presents to your office for an implant, with an implant, and needs the restoration done that day. You see how thinking must change. You see how things can be done with very acceptable clinical outcomes. Because you are judged by your outcome. You see, the patient was probably enamored with the process. We have dentists, though, that aren't necessarily enamored with that. They instead would believe that there's only one way to do things. Right or wrong, it's not really that. Instead, what it is how will you choose to treat your patients, because that will be your decision. Recognizing how markets shift are paramount to your success, because the world fluctuates, and it will within your own lifetimes. I've never could have foreseen any of these things would come into play. But it's a decision that I always was glad that I made, because the shift that we see in dentistry is from shiny to not shiny. In truth, there's no such thing as metal-free dentistry, because many of the materials you'll be dealing with in the future and deal with today are really metal oxides. In truth, they're not truly metal-free, but it's the appearance. And these are things that you're going to have good clinical decision-making. You're going to have to exercise good clinical decision-making skills, maintaining conservation. You see, it's about what you create for yourself. And I like to really speak to this because, you know, a dentist wants to be what? We want people to respect us. Did you see my 20-micron margin that you do? Here, look in the mirror. Look how good these margins are. Now, a patient doesn't understand that. I do and you do, because you know if you do that, you've achieved something. But how do you make a patient? How can you help a patient understand that value? Well, think about what brands are all about. If you see this up here, Mercedes-Benz, what's the first thing that comes to your mind? Some say expensive. Other ones what? Quality, right? Built like a tank, built to last, right? How about that? What is it? Safety. There you go. Right. This one? Comfort. All right. So what's your brand? Now, all I see is a tooth with roots. All right? My point is this. You'll create your brand by how good you are. But how good you are will not be good enough to build your practice. Because I've seen gifted clinicians die at the chair and be very unsuccessful. And I've seen the other way around. How you build this brand will be very important, because this is what brand building is all about. I've got an 84-year-old patient here, a former state representative. And Billy's been around a lot longer than probably he deserves to be. But Billy, too, is one of these people where time is not on his side. As a matter of fact, you would think just the obvious. In other words, I asked him, I said, well, Bill, I says, you're retired, and he came into my office, and he talked to me about this, and he looked, and I asked him, I said, well, you got plenty of time, you're retired, right? And he goes, no, you got that the wrong way. He says, I don't have as much time as you think. Time's short for me. What can you do for me today? what we did for Bill today was to provide an acceptable outcome for Bill. Because you see, again, I'm pointing out, this is in the trenches dentistry. It's not about the fabulous cases that you'll see there. It's what you do every day on a day-in, day-out basis that serves your patient and what allows you to sleep with a clean conscience every night. I did the very best that I could. You are a generation, I'm a boomer, on the late end of the scale, and I guess eventually you'll be supporting me. But you are the generation that are the future of this country. And there's a lot of, I have met a lot of sharp students. I had the conversation last night, and I'm not sure I could have even made this class. But that's another story. You learn one way or the other because your generation is going to demand a different level of treatment. How do you treat a 26-year-old male? Would it be with a crown? These were a couple restorations. The restoration on the left was done 8 months prior to the time I saw this patient. It's a material decision. It's a rather large restoration. Would you treat the patient with a crown? Now, I'll tell you that in the private world, a crown is an acceptable restoration here. It'll be paid for by an insurer. No one will ever question what you do. But how would you treat the patient? In other words, that's you, because you people are at that age or close. How do you treat that? Well, you may want to consider treating them like this, because I don't know anyone yet that can take a composite restoration and adequately build cusps that hold occlusal contacts, shape them into good embrasure forms, and give something to a patient that gives back, with the idea that when that 26-year-old becomes a 46-year-old and may need retreatment again, what will you treat them with? You see, you can treat people like this every day. And this is really what Chairside is all about. Sure, you could do it in a lab, but you could do it just as conveniently as you would do a direct restoration without a lot of time and effort. It's not about being fast. It's about being good. And it's about being efficient in creating value for who and what you are. So we now see, hopefully, that there is a way to marry the wants of the clinician with the wants and desires of the patient. The perception that our 20-micron margins are what we should be admired for, with perhaps the satisfaction that the patient gets in knowing that they have airtight dentistry that's done for them in a very convenient way. Because you'll be making decisions like this for the rest of your careers. And if you look at this patient over here, would you not reason with me that this patient's gone through 30 years of a shift in treatment mentality? From a casting, to amalgam, to a composite, to a full ceramic crown. These are decisions you're always going to be faced with in clinical practice because the dentistries of the 70s, as I explained to you, is much different than what we see today. The expectations of the patients are different. And as I mentioned to you earlier, patients won't come into your office and tell you, well, doc, I think it's about time. My mom lost her teeth, my dad lost her teeth, and I guess my time's come. Those days are rapidly coming to a close. To be sure, they'll be there. You see, all this is a reflection of how dentistry has changed, because when I was in private practice, or when I was a young kid growing up, my doctor's office looked just like this. Practices like this, like you see over here on the left, can look like this. But you know, in truth, when I graduated from dental school in 1983, I think the only consideration I had to make for my practice and what to put in play in my practice was whether or not I wanted a bulb in my handpiece. Because that was about the only thing you could have back then about that time. That was it. Everything else was essentially equipment. You'll have different decisions to make. And what I do know about the dental practice of 2009, and these are statistically accurate, this statistically accurate information, The average dentist, according to ADA standards, is going to make about $200,000 a year, which puts you in the top 5% for sure. It puts you up here. The offices are nice, and we have to make decisions about how we're going to put certain elements of technology into play in our practice. But here is something that you need to really, really remember, because what I remember about my dental office is, and by the way, I think the way I became a dentist was because I remembered one smell that I will never forget, zinc oxide eugenol, was it not? As a matter of fact, today I didn't know where the dental school exactly was, so I was staying over in the bell tower, and I kind of walked through the buildings over there, and without looking at a sign, I decided to walk into one building. I knew I was in a dental clinic because of that aroma. You know, it just smelled like dentistry. It was there. So, you look at the dental office of 1967, here's the comparison. Allowing for the changes today, the practitioner of that time was financially more successful than the clinician of today. And a lot of us are going to be burdened about making decisions in our practice, whether or not, in fact, these systems can contribute something to us in terms of profitability, which will be important to you. Can we do good clinical dentistry, and can we be profitable as well? Can we serve the people that we want to serve and create something of value for them? Because core equipment of yesteryear has given way to core equipment of today. And I can tell you the cost for a practice, as you probably know, is exponentially higher. I will tell you that I was burdened by $12,000 in student loans when I graduated from dental school. And you know something? I had to borrow 5 of that so I could get married to my wife between my 3rd and my 4th year, because I needed money for a ring. When I bought her a diamond, it had more specks of black in it than it had clear areas, but that was all I could afford. And you know, the happiest day of my life was when I graduated and I came home after associating with a senior dentist, and I had $155 cash in my pocket. And you say, what's that got to do with what we're talking about? A lot. Because we want to do good clinical dentistry. And are there ways where we become efficient, and are there ways that we can be profitable and satisfy everybody? Because the role of technology is really about what is being spoken to today, is how do we do things efficiently well, rapid prototype, and follow dictates of industry, which have shown us that this can be done, as Dr. Bain referred to 30 years earlier. How does your practice measure up? What will be your practice philosophy? And how do we remove the negative stereotypes that have been pinned onto dentistry for years? This is where direct restorative care comes into play. Because you can change the opinions of dentistry with the negative perceptions that are sometimes still out there by doing things like this. There is a case for doing direct restorative care because this young man has no options. He wants to have, what? His photographs taken with his prom date. He rolled his truck on Wednesday. And Dad wants something done. Is that in your clinical repertoire today? And do you see validity in perhaps giving consideration to this as you begin practice? You'll also run into situations like this. Here's a reasonable outcome for a patient that had to have an old PFM replaced there. But Marilyn, who's been with me ever since I've been in practice, is now wheelchair bound. And I had to treat Marilyn standing up. I didn't want to do that twice, to be honest with you, nor did she want to be subjected to the same treatment twice as well. Can you achieve a predictable outcome, be efficient, and never, ever compromise on anything that you do? You know, I don't know. Sometimes we focus on things. In and by itself, the structure that you build will not bring patients to you. Dentistry is a very personal service. And the personal level of communication that you develop with your patient, your clinical skills and the appreciation that you naturally want your patients to have for them can be realized if you make investments in yourself. and you always agree to learn. Because I thought that was a really nice tribute there at the end when we talked really about what learning is all about. Because when you go back to the reality of family practice again, you'll see this. This was kind of interesting. This was just done just a couple weeks ago in my practice. This particular patient is going to have knee surgery. It was scheduled like that. And this man only has so much money to spend. Doc, I've only got, and I've got to use it this year. He goes, and I'm going to lose my benefit. And he says, you know, I'm scheduled to have this knee surgery next week. Can we do these crowns? These are a couple survey crowns that I was getting ready to do for the patient. So we're going to do an RPD over here. You can see the two distal teeth over there. They're already prepared and already ready to accept the partial. And then we had done some, actually there's natural teeth. We created some rest there in his teeth. But now he needs the restorations done. So how do I get these to the patient? The patient's pressing me. He goes, you know, Doc, I got to have something done here. Can you help me out? How would you do that today? Well, it'd be a tough thing to do, wouldn't it? Well, technology can save the day because what I can simply do, and everybody knows what copy and paste is, why not just copy the precondition and transfer the precondition to the preparation condition and let the software and let the machine, you can see here the lithium disilicate restoration, create a couple of nice survey crowns for the patient and place them in the patient's mouth because the guy also has a denture. I wanted to maintain the vertical over here. I didn't want to lose that because I'd already created that. That was his natural vertical. He was already wearing a partial. My assistant designed the restorations for me. She glazed the restorations for me. And then when we put the restorations into place, the patient's existing RPD, which was transitional, went to place. Now, I like that, and so did my patient. This is what will drive your thinking as you go forward. In terms of how do you want to invest in yourself and what you invest in with respect to the treatment modalities you're going to offer to your patient. And even things like this, it's not about your building, it's about what you deliver on consistently time and time again, and you honor the tradition, the education that you've had here to this point. Because that is your future, ladies and gentlemen. And in this case, there was some quadrant dentistry that was done here. Crowns are very good treatment for this. By the way, this is the one thing you'll see in private practice. No one can ever explain to me how a stainless steel crown, which fits like socks on a rooster and looks like a lampshade in a radiograph, will go 25 years with no decay underneath it. It's one of the greatest mysteries in dentistry, which is yet to be solved. But I think every clinician out there has seen things like this. These are things that are currently being done on an everyday basis. Patients get implants done all the time, and sometimes you don't have an optimal situation to deal with. In a same-day delivery scenario, you can deliver treatment that meets every good clinical criteria. So what I would say to you is, if you want to live large, make sure you're really, really good at it. And it's going to be a good football game this year. I thank you for your time, and hopefully you'll enjoy the last program that's here.
You've been listening to a presentation from the University of Michigan School of Dentistry, which is dedicated to supporting open learning and open educational resources. This recording is licensed under the Creative Commons. It may be reused and redistributed for nonprofit use. Please attribute materials to the University of Michigan School of Dentistry and redistribute under this same license. For more information on how this and other University of Michigan School of Dentistry recordings may be used, visit www.dent.umich.edu/license.